Welcome to this medicine masterclass on hyperthyroidism. Hyperthyroidism is a clinical effect resulting from excess levels of thyroid hormone. Thyrotoxicosis refers to any condition that results in supraphysiological levels of thyroid hormone, whereas hyperthyroidism refers to conditions in which there's hyperfunction of the thyroid gland leading to hyperthyroidism. Let's remind ourselves of the normal thyroid hormone physiology. The hypothalamus releases thyrotropin-releasing hormone. This tripeptide stimulates the release of thyroid-stimulating hormone from the anterior pituitary, and thyroid-stimulating hormone results in the production and release of T3 and T4, triiodothyronine and thyroxine. T3 and T4 then have negative feedback at the level of the hypothalamus and the pituitary gland. The causes of thyrotoxicosis include Graves' disease, which we'll discuss in a moment, as well as a pituitary adenoma, particularly affecting the thyrotrophs, a toxic solitary nodule, a toxic multinodular goiter, subacute dequervent thyroiditis, postpartum thyroiditis, or drug-induced thyroiditis, as well as over-treatment of thyroid hormones. Stroma ovari is a teratoma of the ovaries which contains thyroid tissue which can secrete excess thyroxine, or a metastatic thyroid cancer. So a number of causes can lead to thyrotoxicosis. Graves' disease is an autoimmune condition mediated by circulating IgG anti-TSH receptor antibodies. These antibodies activate a G-protein coupled thyrotropin receptor, which results in a smooth, diffuse enlargement of the thyroid gland and increases thyroxine production. This autoimmune condition is associated with other autoimmune conditions such as vitiligo, Addison's disease, and type 1 diabetes. The presentation of thyrotoxicosis would be the patient would have anxiety, insomnia, heat intolerance. They may complain of weight loss, an increased appetite, frequent defecation, palpitations, and proximal weakness with muscle atrophy. In the hands, the patient may have a tremor or thyroid acropathy or clubbing. Onycholysis, they may have vitiligo or palmar erythema. The pulse is likely to be tachycardic and possibly irregular as a result of atrial fibrillation. The eyes in Graves' disease specifically would have proptosis, lid lag. In the neck, there may or may not be a goiter. They may have a thyroidectomy scar from previous thyroid disease. On the chest, there may be gynecomastia as a result of increased metabolism producing elevated estrogen levels. In the lower limbs, look for signs of pretibial myxedema, which is a bilateral pink-brown dermal plaques, and test for proximal myopathy and hyperreflexia. Let's focus on the eye signs associated with Graves' disease. The patient may have exophthalmos. They may have eyelid swelling, eyelid redness, conjunctival swelling or chemosis, as well as an inflammation of the inner canthus of the eye. The extraocular muscles become weak, resulting in ophthalmoplegia or diplopia. The patient may also have a relevant afferent pupillary defect, and this is due to compression of the optic nerve due to increased retroorbital fat and increased muscle swelling. They may have von Graves side. This is lid lag. Sympathetic overstimulation caused by overaction of Muller's muscle results in lid lag, and the patient may also have myopathy of the inferior rectus causing an overaction of the superior rectus and levator muscles. The patient may also have lid retraction, and that's where the sclera above the upper limbus of the cornea are visible, and this is known as Dyer-Limpel sign. To manage the eye signs of hyperthyroidism, it's important if there's ophthalmoplegia or any visual disturbance that the patient has cross-sectional imaging of the orbits, either with a CT or MRI. Enlarged extraocular muscles with retroorbital fat, which is inflamed or fibrotic, would suggest involvement. Patients should be encouraged to stop smoking. Symptomatic relief can be provided with artificial tears, sunglasses, minimized dust exposure. Medically, the patient can be treated, so their hyperthyroidism should be treated, and potentially with advanced eye disease, some patients will require steroids or even surgical decompression if sight is threatened. If the patient develops ophthalmoplegia, there may be a candidate for orbital radiotherapy. The thyroid function tests that patients should undergo include anti-TPO antibodies. These are elevated in autoimmune conditions such as Hashimoto's thyroiditis and can also be positive in Graves'. But for Graves' disease specifically, send off anti-TSH receptor antibodies which will be elevated. You can also image the ultrasound with an ultrasound looking for a nodule or a multinodular goiter. And an isotope scan is a useful way to determine the cause of hyperthyroidism and to detect a retrosternal goiter, ectopic thyroid tissue, or thyroid metastases. The isotope scan is there to check whether the nodule has the same uptake, which is a neutral nodule, more uptake compared to the thyroid gland, which is called a hot nodule, or less uptake than the thyroid gland called a cold nodule. And cold nodules are the ones to be worried about, as these can be malignant, whereas neutral or hot nodules are rarely malignant. The patient may also require fine needle aspiration for cytological assessment of the cells. To manage hyperthyroidism, the medical options include beta blockers to help symptom control, particularly the symptoms of anxiety and palpitations. Antithyroid drugs include carbimazole, methimazole, propylthiouracil. Be aware that carbimazole has a serious side effect of agranulocytosis, and so the FBC, or the full blood count, should be monitored frequently, and if the patient presents in a febrile manner, they should be treated as potentially having neutropenic sepsis. Carbimazole is the preferred once daily regimen, and propylthiouracil can be preferred in pregnancy as it's less teratogenic, although both drugs have risks. Be aware that if a patient who is thyrotoxicosis develops sudden weakness following an oral carbohydrate or intravenous dextrose, consider the diagnosis of hypokalemic periodic paralysis, which can last for 7 to 72 hours. If the patient has a tumour, consider surgical resection, particularly if there's a large mass or a large goiter, as this can cause compression of the airway. Remember, there are several risks associated with a thyroidectomy, including consequential hypothyroidism, damage to the recurrent laryngeal nerve, which can cause hoarseness, as well as hypoparathyroidism. Radioiodine is indicated for patients with relapsed Graves' disease with a moderate goiter. Toxic multinodular goiter as well as a toxic adenoma also respond to radioiodine. With this condition, once patients have this therapy, at least for a month, should avoid journeys on public transport, should stay off work or places of proximity to other people, and should avoid children or pregnant patients or pregnant women. In the first 5 to 10 days of this treatment, patients may experience a worsening of the symptoms, but then subsequently should improve. Finally, just be aware of 2 important effects related to iodine. Iodine can cause transient hypo or hyperthyroidism. If iodine causes hypothyroidism, this is called the Wolff-Chaikoff Effect, and if iodine causes hyperthyroidism, this is called the Joe-Basedow phenomena. Thank you for attending this medicine masterclass.